I don't want to call him a guinea pig, but he's a willing participant, and so far he's doing wonderfully. And with me as well is Ms. Tessa Galindo and Ms. Mercedes Baptist. I want to welcome all our guests from Grenada and Ms. Agard, and we want to welcome Dr. Edwards, who will be starting today's presentation. And today we'll be talking about partner notification, which is one of the issues we have recurrent difficulties with, both when it comes to HIV and STIs. There are so many undercutting and underpinning concerns that impact how patients disclose their status and how we can support patients to disclose to their partners and to their loved ones. So I'll turn it over to Dr. Edwards. Dr. Edwards, you have the floor. Thank you so much.
Good afternoon, everybody, and welcome to our lecture on partner notification. So I'm going to share some learning objectives now. At the end of this session, you should be able to describe the aims of partner notification, list the key elements of the partner notification process, evaluate the issues relating to partner notification in primary care, and understand partner notification relating to HIV. In terms of STIs, partner notification, in terms of STI, syphilis and gonorrhea, those are curable diseases. HIV is a chronic, communicable disease. So when you deal with partner notification, there are a couple of different issues. In terms of definition of partner notification, the WHO 1999 comes up with this, which is the process of contacting the sexual partners of an individual with a sexually transmitted infection, including HIV, and advising them that they have been exposed to infection. By this means, people who are at high risk for STIs or HIV, many of whom are unaware that they have been exposed, are contacted and encouraged to attend for counseling, testing, and other prevention and treatment services. Prevention is important there because sometimes you'll contact a partner and the partner may be negative, so what you would do, you have to refer that partner for prevention services. The partner turns out to be positive, then treatment and care services. Just some challenges around partner notification. I have a YouTube video here, and you all can look at it at another time. So once Conrad downloads this talk for you, you can look at the video. So what's the rationale for partner notification? Well, what you want to do is break the chain of transmission. And in terms of diseases like gonorrhea and syphilis that you can cure, you want to prevent reinfection of the index case. As I always mentioned that when I was a young intern, I had my first experience with partner notification. One of the guys, came in with a discharge and we were able to diagnose him with gonorrhea. And I told him, okay, bring in their sexual partner. And he did, And we treated the gonorrhea, treated his partner, And he and the partner were quite happy. And he asked me when he could have sex again. I told him, wait about a week, And about a week and a half later, he called me and said, Doc, this thing come back. So I'm trying to figure out how it come back, and only to realize that he had 5 sexual partners and who weren't treated, so he was reinfected. So we had to bring in all the partners and get them treated. And he decided, you know what? I'm going to stay in my circle of 5 partners. I'm not going outside, because I went outside and I picked up gonorrhea. So that was his rationale. So the index case could be reinfected. Just remember that. We also want to prevent the complications of untreated infections, for example, with gonorrhea and chlamydia, that can lead to pelvic inflammatory disease and infertility and ectopic pregnancies in females, all right? And of course, we think it's our moral or ethical duty to inform people that they've probably been exposed to sexually transmitted disease. So how do we secure partner notification? Well, this is a voluntary process, so you can't force it on anybody. So the patient has to tell you who are their partners. The healthcare worker should adopt a non-judgmental and supportive approach. You have to emphasize the patient choice and that the patient is control. You must emphasize that there's confidentiality And that's very, very important. And so tell the patient that, you know, whatever is said in this room doesn't go out this door. All right. The patient, explain to the patient that if the patient is treated and the partner is not treated, there's a risk for reinfection. And the partner is also at risk for the complications of untreated infection. And of course, if you don't treat the sexually transmitted infection, then there's a risk of transmission to others. So just to show you here, all the different pathways by which people may be infected, the old ones, the not so old ones, same-sex couples, bisexual couples. So just to show you that anybody could be at risk for a sexually transmitted disease once you're having sex. All right. So if you look at the different transmissions here, you can see that all sorts of people are at risk for sexually transmitted disease. So what's the partner notification method? Well, the patient could actually refer their partner. So the patient could contact their partner and say, listen, you know, I've been diagnosed with a sexually transmitted infection. You should go in for treatment. But of course, sometimes the patient may be uncomfortable doing this. So what we have is something called a provider referral, where the patient gives the information to the healthcare provider. And we actually, I used to be the director of Queen's Park Counseling Center, which is the sexually transmitted infection clinic. And we have contact tracers or field interviewers whose job is to go out there and bring in partners of patients with sexually transmitted diseases. So this is a provider referral. Sometimes they would give, the patient would give the phone number, or sometimes if you can't contact the person, then they would give an address, and the contact tracer would go to the address and just tell the person, listen, you know what, we think you've been come in contact with a sexually transmitted disease. No names are called. We don't tell the person who was the index case that they might have been exposed to. We just say that it might have been you might have come in contact with a sexually transmitted infection, so we think you should come in for, you know, testing and treatment. And then there's something called conditional or contractual referral, where what you do is you give the patient probably a week or two to bring in their partner. If they don't bring in their partner, well, the patient gives the information to the healthcare provider, and then the healthcare provider, if after a week the partner doesn't come in, then the healthcare provider goes out and tries to get the person to come in. No. All this is saying that people go out at night, and you know, they may not know the names of the partner, so it is a really difficult process. It's not an easy process. Just to show you a slip, as I said, I used to work at Queen's Park Counseling Center and Clinic, which is the STI clinic, and we'd give this slip. So what we do, we'd put the diagnosis code. So if the patient has gonorrhea, we'd have a code for gonorrhea. If you have syphilis, we'd have a code for it. We'd put the patient file number on it, all right, and the date, and the client would give this to the partner. Once the partner comes into the clinic and presents this, we'd know that this patient come in with a diagnosis, with the partner had, say, gonorrhea, and the client's file number is so and so, so we could actually go into the file and, you know, and record that the partner came in, and also ensure that also the partner did have gonorrhea or syphilis or whatever. All right, so there's a form that the partner brings into the client. So I'm going to show you some more forms again. So sometimes you have some context.
So
yeah, go ahead. Yeah. Somebody's asking a question. Go ahead.
No, sorry, that was somebody just running. Go ahead, Dr. Edwards.
Okay, all right. So there are also contact slips and cards, because somebody will go and their description of the person they were with, that met this girl, she had short brown hair with a red streak, and she had a gold tooth. I don't know her name, and that's the description. All right. So the contact tracer will have to go to the area and ask for somebody with short brown hair with a red streak and a gold tooth. All right. So again, sometimes there's little information available, but the contact tracers use this information to try and see if they could, you know, get the contact and ask the partner to come in. All right. So in terms of identifying partners at risk, we usually look for in the past 3 months for gonorrhea and syphilis and chlamydia, all right? So any partner had, say, within the last 3 months, we look at the sexual history of the patient, you know, ask them if they use condoms or any, you know, other safe sex measure, you know, memory prompts. So sometimes we might be asking the partners, so if it's carnival time, I say, okay, so did you go to any carnival fets? Did you meet anybody in a carnival fete? Oh, yes. I went to this carnival, I got drunk, and, you know, I met this person, and, you know, so you have to give them memory prompts to help them recall. And of course, what you need to do is document these details to track the process. All right, so again, the contact tracers and the healthcare workers sometimes have to trace partners from really incomplete data, as I mentioned, like the girl with the short brown hair, with a red streak and the gold tooth, you know. The contact tracing methods may be phone, a letter, a text, or they actually go out in person. And what they try to do is to get the contact, the partner, to come in. And of course, no names are called. This is a very confidential person. As I reiterate, we just tell them that we think you probably came in contact with a sexually transmitted infection, and we think it's in your interest to come in, you know, and testing on treatment. Again, some of the forms from the QPCC you can see here, all right? Again, it has a description of the patient, the eyes, the hair, you know, the build, the weight. So sometimes there's very incomplete information on the contact tracers, and these are forms that they keep in, they don't share it with the patients. Again, if they do a house visit, again, they will fill out these forms, you know, because sometimes the patient would give the person's name and where they live, so the contact tracer go out and, you know, they'll just go like they come to pay a visit, or is Harry at home, you know? Somebody asked me to come and check Harry, you know, so, and then once Harry is there, they quietly call Harry outside and, you know, tell Harry that, you know, probably came in contact with a sexually transmitted infection, so well, they'll come to clinic. But, you know, it's a very informal relationship that they try to portray. Again, the contact tracer would give this slip to the partner to come in, all right, with the person's name on it, and referring department, meaning a code to say that probably the index case had syphilis or gonorrhea. All right, so there are a number of slips I should show you. Again, there's one for syphilis. Now, nowadays, because of social media, there are some innovative approaches, and young people, all of them on social media, WhatsApp, Facebook, Instagram, all these things, all right? So again, people contact one another quietly on Facebook, but we have to warn them that, you know, they can't post it to the wall so that everybody can see. All right, so you can see what they're doing nowadays in the US and UK and stuff. They use social media, so look at it. I hate to tell you this, you know, you may have been exposed to gonorrhea. Please get checked soon. Oops. Or I'm so sorry, you know, I didn't know I had chlamydia when we were together. You should get tested. So people now use social media to contact their partners to tell them that they were exposed to a sexually transmitted infection and they should come into treatment. All right, and then there's a process that people can go through in the UK. You can go through a number of steps to come up with an appropriate message for your partner. So you go through these steps. But this is a sexual health messaging service. So in terms of partner notification resolution, so you want to follow up for each partner identified. You want to re-interview the patient if the partner is not attended. And again, sometimes we really get scant information. People give wrong names, so the index patient might have a wrong name for the partner or a wrong address. So, you know, if it's just a casual contact. So it's a difficult process. It's not a easy process. And they need to order the outcomes against the national standard. In terms of primary care, we need to advise patients with STIs, all right, that their partner will need testing and treatment. Again, offer them the choices. The choices would be the patient referral, the patient can do it, or if not, the healthcare provider can do it. Now there's legislation in place for gonorrhea and syphilis, so that the contact tracers could actually go out and bring in their partners, all right? And then look at whatever local referral pathways for the management of patients with STIs and again, social media or whatever you have, all right? So in terms of HIV, now HIV is not one of the notifiable conditions. So there's no legislation in place whereby contact tracers could go out and bring in partners of persons, with HIV. So this HIV partner notification is a voluntary process. Where trained healthcare workers, including lay providers, ask people diagnosed with HIV about their sexual partners and with the consent of the person living with HIV. Again, I have to stress this, with the consent of the person living with HIV, all right? You offer these partners voluntary HIV testing, okay? So partner notification is provided using passive, where the patient can do it, or assisted, where the healthcare provider could do it, or you could use a contractual approach where you give them a week or two to bring in their partner. There are some existing World Health Organization recommendations on HIV testing services. So HIV testing services for couples and partners, all right? You should have some support for mutual disclosure. So sometimes a person might not want to disclose their status or may not feel. So what you can do is ask the patient to bring in their partner, and they could actually disclose their status to their partner in front of you, or you could actually disclose the status, HIV status of the patient to the partner. Sometimes they may fear intimate partner violence, and I'm sure we could have lots of talks about that. WHO also recommends community-based HIV testing services, which we do. So we have a lot of testing services, HIV testing services at the health centers, various NGOs do it, all right? And again, what is important that there must be linkage to care and treatment services. So if the person is found to be HIV infected, then you have to be able to link this newly diagnosed person to HIV care and treatment services. If the patient is negative, then you need to link them to prevention services so that, things to condom use, reduce the number of sexual partners, etc. All right. In terms of assisted partner notification services, such as provider or contractual service or dual services, where both the person, the index case, and the provider can do it, this helps increase the uptake of HIV testing among partners of persons living with HIV. And a high proportion of HIV positive people are diagnosed and linked to care in this way. So remember, when you diagnose somebody with HIV for the first time, they're not on medication, so their viral load is not suppressed. So their partners, they're trying to get who they might have picked up the HIV from and then who they might have passed the HIV on to. So that's why we want to try and break the chain of transmission there. Also, you want to put these people on HIV treatment to reduce their viral loads undetectable. U equal to U, undetectable means untransmissible, so that HIV transmission no longer occurs. And then you want there are reports of social harm or other adverse events following voluntary HIV partner notification have been rare, but in our setting, I think intimate partner violence, I wouldn't call it rare, but it does occur. So we have to be mindful of that. So trained providers should offer partner notification services appropriately and safely, all right? Associated counseling and support services such as helpline. So they're trying to bring back the AIDS hotline and intimate partner violence screening tools. And actually we are starting to do that at MRF, trying to ask people about intimate partner violence and refer them to our psychosocial support team. All right, these can be utilized to reduce the potential risk of harm. HIV positive clients should be offered multiple options for assisted partner notification, and the approach selected based on the client preference. If the client wants to tell the partner, fine, they can go ahead. The client may want you, the healthcare provider, to go out and inform a partner that they may have been exposed to a sexually transmitted disease and they should come in for treatment, or the partner might actually bring in, the index case might actually bring in the partner, and you have to sit with the index case and you can disclose to the partner, or the index case will disclose to the partner in your presence. Again, you have to be mindful of the reaction of the partner and be mindful of intimate partner violence, all right? So clients should be also given the opportunity to decide. Partner notification services should be always voluntary. Yeah? Mandatory or coercive approaches to partner notifications are never justified. People should always be counseled over the benefits and risks so they can make safe and informed decisions. All right, so safe meaning intimate partner violence, as I was talking about. Notification should only be delivered to partners of HIV positive people and no one else. So you're not going to tell the family member or the co-worker, all right? The person living with HIV, if they give you permission to talk to the partner, only the partner alone, nobody else, all right? The criminal justice or law enforcement or other non-health related service providers should not be involved in partner notification services. So no need to bring in any police or, or law enforcement or anybody like that, all right? Except in instances where there may be instances where there may be threats of violence to the healthcare worker or to the partner, all right? Now, also we have certain members of key populations. And again, in some countries, like anal sex is criminalized. So again, you don't want to bring in the healthcare, the criminal justice or the law enforcement services, because that would further stigmatize and you probably lose the patient and their partner because, as I say, in some countries, anal sex is criminalized. All right, so that's basically what I had to say on partner notification, and I'll pass it over to Dr. Boyce in case anybody wants to ask questions. I see Yolanda is here, I see Ms. Lizama is here, and I think they had instances where of intimate partner violence, when they were actually notifying partners, and some people actually felt unsafe, when you're carrying out the partner notification process. So Dr. Boyce, over to you.
That was as usual, an excellent conversation, excellent presentation. So I just want to open the floor to anyone who has any questions they might want to ask or any contribution they may want to make on this topic, especially given that the community providers that are here is something that we come in contact with, on a regular basis. Does anybody have anything they want to ask or contribute? And if you're not able to unmute and speak where you are, you can always type your questions into the chat box. Now, I don't like putting people on the spot, but I know we have some members of the psychosocial team, both in the room and remotely. So I won't point any fingers. But I wonder and anyone's free to contribute. What have your experience been in terms of partner notification? Because we always have this issue sometimes, especially on both sides, with women who are afraid to disclose to their male partners because he's in a gang, he's violent, he have guns, he will shoot me, that kind of thing. And the reverse, when a male is afraid to disclose to the female partner because he fear of disclosure. They say this to people in the neighborhood, she go talk of business. What works? What have been your best practices? And again, I open this out to anybody. And just a question from Leon Omari. When carrying out partner notification with a patient who is currently at risk of IPV, how does one proceed? Dr. Edwards, can I ask you to answer that first? And maybe some of the
I think probably the psychosocial team, Ms. Lizama, should be able to handle that one. Ms. Lizama, she's there?
Yes, I'm here.
Yeah.
Could you repeat the question that Omar is in the chat?
Yeah. So when carrying out,
who's currently at a risk of,
yes,
and how does one proceed? Now, let me just step back a bit. Now, with regard to partner notification of each patient, and all the new patients are asked about partner notification, if it hasn't already been done yet. What usually happens is that sometimes a partner who have already been tested positive would have informed this particular patient who is being admitted at that point. So in terms of partner testing, that has been carried out. There are times that patients may not be able to identify a particular partner. They may have several partners. They may have one partner whom they probably would have disclosed already or have not. So we encourage that person to do so. If not, then we also give support for disclosure if it is that they cannot do it themselves. Now, there are times that that issue would come up and they would indicate, look, if I can't tell this person now because he is violent, he is that, but what may happen is that we would arrange certain situations where partners can be tested either not here but some other place, or we can arrange for both parties to come in to have HIV testing done. Now, Omari asked, when carrying out partner notification with a patient who is currently at risk of IPV, usually, the thing is, we haven't seen, at least I have not seen intimate partner violence for a while, because it all has to do with, how the notification, or if there is to be a notification. The answer is that usually, I think that most likely would that would be afraid of the intimate partner violence. But you also have both having that they have problems disclosing, or that the male or female may not want to disclose, but generally I think that persons disclose. That's it. In between, you would have persons who may not want to disclose because of certain issues, either that, okay, they may not be violent, but they may want me to leave the relationship, or they would separate from me. That fear that may happen is that the person may lose that financial backing of the person. Okay, I cannot disclose, or this female may leave because I'm now positive, and lots of cases too, you find that the persons who they have to disclose to are already in the clinic and they don't even know that. And the thing is, we cannot tell them. So it is a situation where it may be on both sides, as with regard to the violence.
Yes, I've had a number of instances where people tell me, Doc, I want to tell my partner, but so both of us coming in for the first, so we coming in to test.
Orange, yeah.
I'm coming to test, although you know I'm HIV infected, so they both will test. And of course, the HIV infected person will be HIV positive, and the partner may be negative or positive. So again, they will do it like that both of them are coming in for the first time for tests. And again, they put me in this awkward situation, but we just carry out the testing and give the results.
But
sorry.
What has been happening with regard to the form that we are using? It's a form that we started with, and which is supposed to have been reviewed by Ministry of Health, because since we started it has not been reviewed. It's pretty long, and I think the last meeting that we had, when was that? With regard to that form, we discussed the partner testing, etc. But what we wanted to do was to kind of bring it down a bit for it to fit to the MRF staff when they're doing this partner testing, because it's kind of lengthy And then after having gone through a number of questions, although it can be autofill, but the questions are pretty lengthy. So we're trying at this point to lessen the number of questions and to at least to bring it to MRF use.
Right. I see Yolanda is there. Yolanda, you want to tell us, I mean, you know, in terms of partner notification, some experiences people may have had in terms of partner notification. I know you probably would have had quite a bit of experience with it. You can unmute and speak. Don't know if she's hearing. Yeah.
Thank you, Dr. Edwards. Good afternoon again. Actually, I just saw a post there by Miss Belinda White, and I think that's spot on. Before any notification can happen, I guess first you have to get the patient in a level of comfort, because there's a lot of anxiety. There's more anxiety with partner notification, I think, sometimes with receiving the test itself. So you have to work with the clients to get, to allay their fears. And as Ms. White said, there must be a plan. Because, I mean, the realities are that it can become a volatile situation, which you don't want to happen. But I think, apart from with the healthcare professionals, I think one of the good things that is happening and continues to happen at the center is the peer support. I don't know what is the latest name now. I know they used to call them navigators and all kinds of things, but I call them peer support. People, HIV people talking to HIV people and allaying their fears, and also relating to them some of their lived experience, which will help them to feel better about why they need to do it, the benefits of doing it, and if your relationship is stable, if he or she really cares about you. It's a hurdle, yes, but it's not a hurdle that we necessarily need to not get over. We can get over it together with support from professional support, people like Charlene, etc., etc. Um, so yeah, I have seen. I continue to see that. In fact, it's such an interesting time. I have had between last Friday and today 5 persons who are HIV positive. A couple of them, I think they are members of MRF, but 3 of them are not. In fact, they have not disclosed to anybody for over 10 years. They are sitting in spaces where they are scared, frightened. They haven't told partner, they haven't told family members, they haven't told anyone. And I was wondering, how do how do I move these 3 folks from where they are into spaces like the MRF and other spaces where they can get support? In fact, I would say, is Wayne on this call? Is Wayne Jackman on this call?
Seeing Wayne.
Perhaps not. But I did reach out to Wayne, and we're having a conversation about how we can support and bring them into care. So yes, it's not a ticklish situation, but really it's a situation that demands a lot of empathy. And above everything else, we have to follow the lead of the client stroke patient. We have to help them, move them to that space of disclosure where they can see the benefits of disclosure. I've also had another interesting situation where a dear friend of another HIV positive person breached their confidentiality. And they told me, well, Yolanda, we did it because we wanted to protect other people who they felt that the person was, going to have a relationship with. And the person they were going to have the relationship with reminded them of their 21-year-old son, and yada, 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 yada. So there's a lot of interesting things going on. And I think too, not that there's any lack of information, but I think it's how the information is disseminated. I think, you know, we need to remember it's a continuum and people are on different levels. So how do we, I never say go back, but how do we get to, with all the platforms that are available to us, and Dr. Edwards, you talked about the young people and their brashness with social media. Yeah, and that is happening a lot now. So it's an interesting dynamic, and I don't have the answer, but I think if we all put our heads together, we could come up with a number of strategies, because it's not one strategy we need a number of strategies in terms of how we engage to ensure and support the folks to improve their quality of life. Thank you.
For that. I just want to go back to the chat box. So you also asked, one of the questions was, what are the intimate partner violence screening tools? I wonder if there's any member of the psychosocial team that can answer that just briefly for us. What tools you would use to screen for intimate partner violence? And the second question from Omari: do we educate patients on different types of abuse, such as emotional and financial, or do we observe and identify based on interactions when dealing with partner notification? So let's open that out to anyone in the psychosocial team if they'd like to contribute. Don't make me have to call on anybody.
Hi, good afternoon. Belinda here. With regards to the question asked on the screening tools that we use, we don't have a specific screener that we use for GBV. There's a checklist that we developed here at MRF for our use, which includes GBV. So it sort of identifies all of the high-risk behaviors or high-risk circumstances that clients could be exposed to. And our goal is to use this checklist with all newly enrolled patients. And a part of that checklist, as I mentioned, GBV is included in there. So it's part of the intake process where you ask a client a question, and once they've identified that they are being exposed to some sort of violence in any way, and of course, this sort of ties into Omari's question. So the staff at MRF has been trained on the different types of abuse, right? And so we are more keen to identify the different types of abuse that may exist, even though the client is oblivious to the fact. So once we've identified that a client is being abused financially, emotionally, sexually, etc., we can pinpoint that, right? And then we take it from there. In terms of educating the clients, that is something that we sort of have to take in stride sometimes, because clients, when they are being abused, as I mentioned, they are oblivious that they're actually being abused, and we have to be sensitive in how we relay that information to them, and we have to be delicate and empathic in how we communicate that to them. So on the day that they are diagnosed and they're having that intake procedure done with the nurse, and it's already a very overwhelming experience, it may not be best to point out to them. Well, it can be helpful, but it's all about the way within which it is done to ensure that the client is receptive to what we say, because our goal is to ensure that they are retained in care and that they continue to be open and transparent with us. And so we have to be mindful of that. We can't educate them over a period of time, because they will continue to be our clients. But the most important part of it is for the healthcare provider to be aware of the different types of abuse that exist, so that they can identify it. And the particular screening tool that we use, as I mentioned, would be that mental health checklist, which is a very comprehensive checklist that we've developed for our use, so that we can all sort of identify the different behaviors that need particular support, and the necessary referrals are done. I hope that answers the questions.
In addition, Belinda, Shamim here. Hello? Hello? No. Okay.
Sure.
Hello?
Yes, Charmaine, you could go ahead. We're hearing you.
Okay, so in addition, the index testing form that we use for partners of clients that we are testing, there are a few questions on domestic violence. So we also can, in addition to the one that we use for the inpatient, there is also one to be partner when we do the partner testing. So there are a few questions on domestic partners.
Thank you so much for that. So if there are no other questions or comments, I think we should probably just proceed to the case at this point. So thank you so much, everyone, for your contribution so far. And just give me a second, let me pull up today's case.